Our first speaker for this afternoon is Dr. Lee Duc Tin. He's from Ho Chi Minh City and he works at Cho Ray Hospital. Please, he's going to give a talk on occlusion of the common and internal iliac arteries for aortoiliac aneurysm repairs. How I do it safely. Please.
Yeah, hi everyone. I'm so very happy to stay today and talk about within the endo. Which topic I just tell about in the common and international iliac artery occlusion. So just the first time we know about in the endovascular have problem about in the stenosis or any problem about in the internal access. That's so very important some scale if you want to the EVA. I just talk about in the AUI. Yeah, AUI that's so very important. Some scale that's in the residue if you don't boost in the stand in the bifurcation and you have to need to yield in the AUI. Yeah, and if you need the AUI, maybe you lock in another side and you are not by in the surgery or not by in the endo. And another doctor could combine together about in the AUI and the bifurcation endovascular. And so they are similar to so many the doctor. But on also the people thinking about in the bifurcation and the wrap that's so very useful more than about in the AUI. But in another doctor to thinking about that's the same. And so within the research to compare together about in the short time and long time and to see in the third day outcome you can see in the MI and the heart failure to the responsibility that is so very different, but sometimes it is not different. And follow to in the 1 year, you can see so many the MI and have problem about in the respiratory that is different. But in the stand wraps, marization or in the stand wrap occlusion or any problem about today, for example, and the list that is not different about in the AUI and bifurcation and the wrap. I just want to tell about in the internal iliac artery occlusion. So you know in the have problem about in the abdominal aneurysm is tension to the common iliac or outside, and that's so very important. Do you want to define with this? And occlusion to in the international iliac have to need to do in some in this case to understand that. So you know another author to meet in the problem about in the common iliac aneurysm to meet in the 45%. And that's so very difficult if you want to do it and you have to need to extend in the common iliac artery. Have a problem if you want to extension in the common iliac, you lock in the internal iliac. Maybe you have problem the ischemia to in the pelvic. And for the guideline to recommend to do just only one to the occlude in the one in internal iliac artery, and which in the so very strong 1A, and recommend to in the is to the one or which or to which after that do you want to do in the end the wrap. And in the occlusion within the internal iliac by in the blood or any the operation, we can see to you when the vascular blood maybe you oversize within the 40, 30 or 50% oversize of in the vascular diameter. And sometimes we use to in the device that is suitable for that. Before sometimes you want to the side or opposite, maybe you choose to in the device that is suitable for case before in the anatomy. And How can we occlude to in the internal iliac occlusion by coil? Yeah, which by coil you just choose in the diameter is suitable. Maybe you oversize in the 15 and or 20% more than of in the diameter vascular. You need to coil deploy within the situation of in the tongue of in the internal iliac artery before the coronary to the branch of in the internal iliac artery. That's so very important to supply for the pelvis vascular. Yeah, in the picture you can see, yeah, just the first picture to see in the to boost occlusion to extend in the two branches. That's so very full. And another picture you can see to the suitable situation and that have so many the blood to coronary by to another side for together and supply to the pelvis. That's so very helpful. Yeah, so another research to compare together the coil and lust in the internal artery iliac occlusion, and you can see so between to the internal between residue to different about in the coil and lust. For research, just only to see in the 17 day for the coil, just that is so far in the blood. And another table, you can see the long-term outcome. You can see in the block occlusion that is so very different about today. In the 5 and 4 compared together, then 11 days. Yes. My opinion, I think so. So many the tip within the internal iliac artery occlusion, we use to the long 6 front and 7 front and 45 and to support. Rush over about if you want to knit in the opposite. Maybe you can to see the same side or the overall depend on in the anatomy of the internal iliac artery. And so many the device you use, maybe catheter, anything else, or stepwise or central wrap for to the depend on the anatomy of in the external iliac artery. Maybe you can use to choose what do you want to assess. And you choose a coil or emblazer, depend on for you, depend on the diameter which in the internal iliac do you want to join. Sometimes you look about carefully in the calcify which in the vascular. Sometimes you can look carefully about so many colorant. Sometimes you can see to join with a sat is suitable. Yeah, and my conclusion, I think so to if you want to boost in the, if you want to do in the EVA procedure suitable, maybe you can choose to the landing zone is so very helpful. And maybe you can react to the new play or react to the new landing zone, or maybe you want to keep in the internal iliac. You want to choose to occlusion or no, depend on which in the anatomy of depend on in the one scale. Yeah, and but in the principle, you keep to the supply of in the pelvis. That is so very much, and you, after that to enough in the supply to in the limb. And sometimes so many cases to have a complete anatomy. Maybe you use to in the endo first. After that, maybe you can open surgery if you want to occlusion it. Yeah, and my opinion, I think so. Depend on in the coronary in the pelvis. Maybe you can perform in the EVA. After that, in the 1 or 2 weeks. After that, you occlusion in the internal iliac artery. And the surgery, yeah, my opinion, I think so. The surgery that's so very happy. So many scale. That's confirmed to easy if you want to EVA. But some scale, the patient is so very old and combine together the high risk. You use to the surgery that is not helpful. But the first time you can see to the endo first, I think so. Yeah. Yes, thank you.
Is there any question for Dr. Tim? So to preserve the pelvic circulation, there's many tips and tricks to preserve it. You could use an IBD or you could do a PMEC like Dr. Wila had showed us this morning. I have a question for Dr. Kwang. Personally, do you like to coil, embolize, or plug as a cardio-interventionologist?
I think I myself prefer the plug. Going faster and also it saves the time, because usually when we do in the when you have a long list of the patient waiting, you don't want to waste too much time, and the coil is the reason is a little bit like uncertain in some way. Sometimes you I think the PDA can close more complete and also avoid the like a reconnection after that. So and also that in terms of technique for the people, especially when you do the EVA, some vascular surgeon maybe become more familiar with the plug rather than the coil. So I think the PDA, the plug should be the first priority.
How much oversize you use if you use the plug?
I think usually I think the 30% is something like the normal one. Somehow we also need to think about the further progression of the IMA in the long run. However, because in reality you can see some subset of the patient only got isolated the aneurysm of the iliac rather than the total the abdominal aorta. So in this type of the patient, you should consider a little bit higher oversize. For the normal case with the TPOA with the aneurysm in iliac, you can consider like a 30%.
Okay, Dr. Tin, you use how much oversize you use for the plug? Also 30% or less?
The blood we usually do oversize in the 30 or 50%.
Okay.
Yeah.
The reason I ask is this: if we use the plug, usually the recommendation recommend maybe 40-50% oversize.
Yeah.
And the problem is if we use, let's say, 40% oversize, then it will be long. It will be elongated. Yeah. Then what Dr. Tin mentioned that we should not go beyond that internal iliac bifurcation. Yeah. Then we will go into either posterior division or anterior division. Then we will block that collaterals.
Yeah.
I heard somebody trying to preserve that bifurcation. Yeah. Now it's too long. It protrudes into the common iliac. Yeah. Then we get bad thing either down there or up there. So too much oversize may not be good. So maybe 20%, 30% that you mentioned will be good.
I made some scale today, but my idea, if we scale, maybe you try to oversize to lower. Yeah, and sometimes some scale I use to another side to set, for example, in the same side to set in the balloon. Yeah, and balloon I clock today with, and that's so very suitable to come to the outside to go down. Okay, and maybe that is exactly if you want to boost to employ today exactly. I think so.
May I ask one more question? Coils. If you use coils, how many coils you use? So because we see people, sometimes we kind of pack the internal iliac so so tightly, but some just put a few coils. Is okay with thrombose. What's your suggestion? You use a few coils enough, or we have to put a lot of coils? Make sure it.
I like to the laser more than in this coil. Before laser, that you can suggest or you can doubt it about to in the long and the diameter exactly. Before you know in the internal iliac artery to divide into two branches. Yeah, and the principle you just only to boost in the tongue of in the internal iliac artery.
Right.
The coil that's so very unsuitable for you, and sometimes you in the catheter come to there, and maybe you don't keep control to in the situation. After that, do you want to move?
Right. So
and I like in the M laser.
Okay.
But sometimes if don't have to the M laser suitable, I use in the coil.
Yeah, you use coil, you use plug.
If I do it myself, I use coil. It's fast and easy. But if there's an aneurysm of the internal iliac, we need coiling, I'll use the intervention radiologist to do it for me.
Okay. Janvila, what do you think?
Yes, okay. Thank you so much.
In my hospital, no plug in my hospital. I use only coil. But in some challenging anatomy, sometimes I use the larger size of iliac limb to cover the origin of internal iliac artery, like the Dr. Sulakiat present for the case this morning.
I think the same like Dr. Thin mentioned. I think plug will be easier. Dr. Kwang mentioned just one plug, finish. No need to put too many coils. But if the internal iliac trunk is short, then I think sometimes the plug is not quite good option. It will be too long. Either go into the branch and things. So I think either coils or plug can have, depends on the anatomy, I guess. If the internal iliac is a bit short, which we don't see that often, but 2-3 centimeters in some cases, maybe coils would be safer. I don't know. I just propose something that maybe we can use both plugs or coils. If the anatomy is suitable, plug will be easier, cheaper. Something like that. So, well, thank you.
And I'm so sorry. So just in my opinion, I think so the blood, that's so very difficult if you want to access before you yield to the catheter. The lungs is but easy to employ, but the coil too easy, you come to down, but so very not suitable for you when you keep control today in the employees. Yes. Okay, thank you.
Thank you very much.